Welcome everyone to IsisParenting's Breastfeeding Chat and Learn. My name is Nancy Holtzman. I'm a mother-baby nurse educator, board-certified lactation consultant, and board-certified in pediatrics, and I'm here at IsisParenting's home office outside of Boston, Massachusetts. I am the clinical content and online learning vice president here at ISIS, and with me today in the moderation role is Hillary. I'm just looking because it looks like she's gone from the. Oh, there she is. So thank you, Hillary, for being with us today in place of Katie and our other helpers. Today we are going to talk about the early days of breastfeeding. I'm dividing it up to the time in the hospital and then the early days when you are discharged home from the hospital. And this topic was a request from a friend and coworker of mine, Liz, who's expecting her second baby. And yesterday on Twitter, I asked my followers if they felt that the first 2 days in the hospital or 3 days in the hospital were more challenging, or if they felt that going home from the hospital, for example, day 3 to day 7 or so, was more challenging. And I was not surprised at the results. I personally think that they're both hard, and everybody actually felt that both scenarios were quite hard. Some people had challenging hospital experiences, and we'll talk a little bit about what you might expect from the hospital experience and how to get the most positive outcomes of your hospital time. And then many people described some of the challenges in the early days at home, and we'll talk more about those next week. So let's just get started because there's a lot of information here, and I'm going to try to move through it as an overview and then hopefully answer some questions at the end. So if you do have particular questions, you can put them in the Q&A box, and I will answer some of them toward the end of today's presentation. So I'm making some assumptions here, which are big assumptions to make, but in today's focus, we're going to talk about when a baby is relatively full-term, relatively healthy, and there's no sort of extenuating circumstances, and I'm just kind of looking for the overarching, fairly typical scenario. So in the perfect world, mom has her baby, and if it is a vaginal birth, then hopefully the baby and the mom are going to be awake and alert, and the baby hopefully will end up on mom's chest and hopefully at mom's breast and go on with some bumps in the road are very common during the first few days and particularly the first few weeks of breastfeeding. But getting some information, some support, sticking with it, overcoming some challenges, and going on to have a very positive breastfeeding and pumping relationship. And that would be the perfect world. But we don't all live in the perfect world, so we'll talk a little bit about some contingency plans later on. So I do want to emphasize the importance of skin-to-skin after delivery when possible, when feasible. And for a vaginal birth, often the baby can be brought right up to mom's bare chest, and the initial assessments can be done right on mom's chest, and optimally there would not need to be separation for routine care. This would be the uninterrupted hour or so after delivery, and this is called the magic hour, and we'll talk about that in just a moment. And there is also a new movement called family-centered cesarean birth, and we've been talking about it for a while, and we've been seeing aspects of it for a while, but it's really focusing more on mom and baby during the C-section, and I think that many of you know that about 33% of babies in the United States are born by C-section now. So that's 1 in 3. That's a lot of babies being born by C-section. And in some scenarios, if the mom is healthy and the baby is full term and things are uncomplicated, there are some accommodations that can be made in the OR in certain situations so that a clear drape can be used, mom can see the baby being born, the baby can be brought skin to skin right after birth, and perhaps even perioperative breastfeeding. So some of you might know that during a C-section, the baby is born in about 10 minutes of starting the operation, but the operation itself continues on for about 45 minutes longer, and that's all the closing stuff. So it's very easy to kind of go in and take the baby out, and then it's a lot more complex to layer by layer put everything back together. So during that time, mom and baby can be getting acclimated, baby can be getting skin to skin and perhaps even breastfeeding. If your hospital doesn't participate in this type of offering, then very often skin to skin can be done in the recovery room or the PACU. These might be things that you need to ask for. And in fact, we're doing a webinar tonight on family-centered cesarean birth and how to promote this or request some of these methods in your birth facility. And I'll put the link up for that later. The skin-to-skin time frame after birth is a very important time in terms of the baby's adaptation, and we do know that skin-to-skin is the best place for babies to regulate from life in utero to breathing room air, maintaining their body temperature, learning to open their eyes, learning to hear mom's voice more clearly, and so on. There are 9 phases of what happens typically during this first hour, and the ones that you probably have heard a little bit about is that the baby may instinctively inch their way toward mom's breasts and may use their hands and their face and their eyes and their nose to locate mom's nipple, and may actually even be able to lick, nuzzle, or latch themselves on. It's okay to put baby at the table, so it's okay to help position your baby and help them get latched on. But the skin to skin, and I want to point out what's truly skin to skin, which is the baby is bare chested except for a diaper and a hat, and mom is completely bare chested, so there's no bra on there, and then a warm blanket can cover the both of them as long as you can visualize your baby's face and head. But I want to mention routine care, because if everything is going smoothly, you can request that routine care be delayed and that you have this uninterrupted period of time for skin to skin until the first feeding is accomplished. Because very commonly what happens is the baby is delivered, is brought to mom's chest, mom is wearing a hospital nightgown, a Johnny, and the baby's put on the Johnny, and then some towels are laid over the baby, and the baby's briskly wrapped, and then mom gets a few minutes to look at the baby's hands and feet and face and hair, and then the baby is actually taken away, is weighed and measured, may get what's called eyes and thighs. They may get the eye ointment and vitamin K injection, and the baby is diapered, put a little undershirt on, and then usually swaddled up nice and snug like a little burrito, and then handed to partner who then sits next to mom. And while mom, meanwhile, is delivering the placenta, the afterbirth, maybe getting cleaned up a little bit down below, and then the baby, all swaddled, is placed back at mom's chest to achieve that first breastfeeding. And that is that's not evidence-based care, and these days you might consider asking for something other than that. So not having that routine care, the bathing, the swaddling, the diapering, not having that happen until you've had that uninterrupted hour of skin to skin and you've had the opportunity to offer baby first breastfeeding. Whether or not baby achieves the first breastfeeding, it may not happen during that first hour, but at least you're putting the baby at the table and you're offering the opportunity. And then there are certain situations where skin to skin just can't happen during the early time frame. So if a baby is born prematurely, if it's a C-section and you don't have that option for family-centered care, if there's a complication during delivery, like maybe mom is bleeding heavily, or maybe there's concerns that there was meconium aspiration and they want to suction the baby. So there are reasons why mom and baby must be separated short term, or sometimes even longer if the baby does need to go to special care nursery. But the message I want to give to you here is I don't want people to feel like if that magical hour can't take place, then bonding is forever affected and breastfeeding is affected, and these things are optimal, and this is what in the perfect world you can request and hope for, but moms and babies absolutely go on and bond and breastfeed even if they can't do skin to skin during the first hour, or even if the baby does need to spend a night in the special care nursery, and even if babies are born 1 or 2 months premature and actually need to stay and get stronger and healthier and stay overnight in the NICU for a period of time. So don't think that all is lost if you don't get to achieve this skin-to-skin time. However, be aware that it is a very important and special time, and it's something that you do want to aim for. So whether it is minutes after birth, hour after birth, or the next day, early on, you want to achieve that first feeding. And remember that in utero, baby is getting everything they need, so they are well hydrated, they're not particularly hungry, they're not particularly thirsty, but they have been practicing sucking very early on. So babies in utero will suck anything they can reach, which is their own fingers and toes, because they're scrunched up in a ball. They'll suck their umbilical cord, they'll suck their wrists. Some babies are actually born with little hickeys on their forearms because their forearm was in front of their mouth and they sucked it. And some babies will suck their lip, their bottom lip. So they have been doing that in utero, and they get used to doing that. And when you're trying to get them latched on, you have to kind of draw out that bottom lip. So babies have been practicing sucking all along, and when they feel that nipple, the nipple, as you know, darkens during pregnancy, and that is sort of a visual target, like a bullseye. The darker nipple against the lighter color of your breast gives the baby's blurry vision something to aim for. They have that rooting reflex, so they feel the nipple against their cheek or the corner of their mouth, and they do turn their mouth toward it. And when your baby latches on and sucks, it does create an oxytocin response. And oxytocin is the natural hormone that contracts smooth muscle, and this is what allows the tiny, tiny little connective tissue muscles in the breast to contract along the milk ducts, and it pushes down and out the milk, in this case the colostrum. Now, Pitocin is the natural form of this contracting hormone, and it also makes the uterus contract. So the artificial oxytocin is called Pitocin, and I'm sure you've heard of that. And Pitocin is sometimes what's used during labor to augment or induce contractions. Sometimes Pitocin is used after childbirth to help the uterus kind of clamp down and reduce bleeding. And when your baby latches on to the nipple and sucks, your body will have an oxytocin response, and many women will experience some uterine cramping from that too. And even a week or two after, when you're at home and you sit down to nurse, you may have some cramping that feels like a menstrual cramp, and or you may have another little gush of bleeding, which is called lochia. So in the couple of weeks after you have a baby, you will have some vaginal bleeding, kind of like a period. And it tapers off usually over about 4 to 6 weeks. And some women, we were talking about this on Twitter yesterday, not frequently, but some women experience the uterine cramps very, very severely. So rarely, but some women will say that the uterine cramping after childbirth was worse than the labor pains themselves. So don't be surprised if each time you sit down to nurse, you have little contractions or cramps or some brief pain or discomfort, or you bleed a little bit more when you sit down to nurse. That's normal. And this is why breastfeeding, this is yet another reason why breastfeeding is beneficial, because women that breastfeed will have less blood loss and lower rates of anemia. So ultimately, anemia makes you feel tired and drawn out and so on, and it's from blood loss. So the breastfeeding contracts the uterus and helps prevent increased bleeding after childbirth. Another reason why you want to do that first breastfeeding, hopefully within an hour after delivery, is because hopefully it's going to be one of the very first things in the baby's mouth. And so they are in some ways imprinting on the smell and the texture and the taste and the location. Not all babies are actually going to latch on beautifully and suck and swallow, but even if they lick and nuzzle, it's considered a success. Remember that your baby doesn't actually need nutrition within an hour or 2 or 3 after birth, but those early mouthfuls of colostrum are the perfect thing to coat their mouth, their throat, their digestive tract, teach them how to suck and swallow, and latch on. And the other thing to know is that usually within a couple of hours after birth, the baby is going to take a long, hard sleep. So babies usually have a period of about an hour to 2 hours where they're a little bit more awake and alert, and then they may kind of shut down They're exhausted after that long trip down the birth canal. It's been quite an adventure for them, and they are ready for some sleep. So you really do want to try to get that first feeding underway in the labor and delivery unit or in the recovery room if you had a C-section, because chances are at 3 and 5 hours after delivery, it's going to be much harder to feed your baby who might be quite sleepy. Just another few good words about colostrum. Remember that colostrum is milk. So some people, and actually some cultures, don't think that colostrum has much value, and will often talk about supplementing a baby until the real milk comes in. And colostrum is real milk. It's the early milk, and it's critical, very, very important and very beneficial to your baby's immune system. And it's important that it is the first thing and the main thing that coats the baby's GI tract during the first day and two after delivery. And in fact, colostrum is so important that even babies that are in the intensive care unit and are so young that they're not yet ready for oral feedings, they're not even ready to breastfeed or take a bottle yet, the medical team will have mom expressing colostrum, and then they will use the colostrum on a cotton swab inside the baby's mouth for mouth care. So that's how important the colostrum is. It really is like baby's first vaccination. It is chock full of antibodies and of growth stimulating hormones that coat the baby's GI tract and make the GI tract more amenable to digesting milk in another day or two when there's more abundant milk. Having colostrum in there first really primes the baby's gut and intestines and immune system. And it also is very high in protein, and that helps maintain baby's blood sugar. So a couple of things that newborns sometimes have difficulty with is maintaining their body temperature. So we have to keep them warm, and skin to skin is a great way to do that. And another thing that some babies have issues with is keeping their blood sugar up. So colostrum is very good for that. And then another issue that rears its ugly head during the first 1 to 2 weeks is jaundice. And one important thing about colostrum is it has a very potent laxative effect. And that's important because your baby, their GI tract is full of meconium. And they actually have what's called a meconium plug in there. So hopefully they don't have a bowel movement until they've been born. So some babies jump the gun and they'll pass a bowel movement in utero or during the birth process. But in the perfect scenario, they don't do that and they wait until they are out of mom before they have their first bowel movement and pass that meconium plug. And by giving them frequent dollops of colostrum over the next 24 hours, it's like giving them a little bit of a laxative every few hours, and it's going to help all of that meconium clear out of the GI tract. And the reason that's important is because the longer that meconium sits in their GI tract, the more chemical is reabsorbed through the intestinal lining that creates the jaundiced situation. And jaundice makes a baby turn yellow, but it also makes a baby very, very sleepy, and it's difficult to feed a jaundiced baby. And so you end up in this kind of downward spiral of a very sleepy baby who's not feeding well. Since they're not feeding well, they don't poop much. Since they don't poop much, they get more jaundiced. So if you can just remember that colostrum is like a laxative, and it gets the baby pooping, and poop is good. The more your baby poops during these early days, the less likelihood you'll be worrying about high bilirubin levels and jaundice. Also, frequent nursing at the breast or expression, if that's what you need to do, is what's going to ultimately stimulate your milk production and helps your milk come in, your milk come in more abundantly sooner. Okay, so these early days, and you see I keep referring to it as days because you know, you may have been up for 24 hours, 36 hours solid. You may have had a night at home. Maybe you can share in the chat room before your baby was actually born what was going on. Because a lot of times people are in early labor and they're kind of, you know, dozing a little bit in between some contractions, walking at home, excited, going for walks and things like that. And then they finally go to the hospital, and then, you know, it may be 12 or 24 hours in the hospital before the baby's born. So there's a lot of excitement, there's a lot of adrenaline, and there's a lot of sleep deprivation going on, and that's all before your baby even arrives. So you're not going to be in such a conducive learning retention mode during your baby's first 2 days of life. And that's why I'm so happy that we have people like Sarah on the webinar today, who is due today with her first baby. So most likely sometime between today and 10 days from today, she's probably going to have her baby. And she's learning ahead of time because here at IsisParenting, where we have childbirth education classes, newborn essentials, and breastfeeding basics, a lot of times we have to educate families on the phone who say, oh, I was told that the hospital has a breastfeeding class after the baby's born. Or they might say, I didn't know I needed to take a breastfeeding class before the baby's born. I thought I would take that after the baby's born. But you know, your baby is born and needs to eat within the first hour, as we've discussed, and then probably, 8 or 10 or 12 times in the next 24 hours. And so, yes, you'll be doing a lot of on-the-job learning, but having all of this types of information ahead of time is going to really be beneficial because you'll be able to recall information and not try to learn information and retain it during a time frame where your body and your brain is really not a condition to learn things. You do want to try to feed your baby 8 to 12 times in 24 hours because not every time is going to go well. There will be times where the baby just can't latch on. There will be times where the baby latches on and promptly falls asleep. There will be times when the baby cries. There will be times when you cry. And if you're trying to feed your baby 8, 10, 12 times in 24 hours, it's perfectly fine if a few of those don't work out. If you're only trying to feed your baby 7 or 8 times in 24 hours and 3 or 4 of those feedings don't work out, then your baby is kind of getting some minimal marginal feedings in there. So when your baby is awake or waking up, is alert, those are good times to put them to the breast and see if you can work on a little bit of feeding. It's also great to stimulate your milk production, so putting the baby to the breast early and often will bring your milk more fully in sooner. And realize that the baby is not a clock and they're not going to eat every 2 or every 3 hours by the clock. They often will cluster feed. They may have an irritable or cranky time frame where they're on and off, and then they may sleep solid for 3 or 4 hours. You want to listen for swallows, and they sound like this, kind of like a soft K or a soft in the back of the throat or a soft little puff of air. As your breasts become more full, you'll notice a softening after feedings, and that's a great sign too. Do massage and gentle compression during feeding when the baby's latched on. You'll be paying attention to the diapers. As I mentioned earlier, the first thing that happens over the first 24 to 48 hours is first they pass the meconium plug, and that kind of looks like black, sticky, tarry stuff that's very hard to clean off the baby's skin. And then as they begin to get more colostrum, and then as the colostrum becomes more dilute, as mom's milk starts to become more abundant, you'll see transitional poop, which looks greenish black. And then once your milk is in more abundantly, and this is usually once you're home, gradually as the baby gets more volume of breast milk, you'll see the poop start turning yellow. So you'll see this transition from black meconium to transitional poop to yellow breast milk poop. You'll see more wet diapers in the first day because your baby is born hydrated from life in utero. And then the second 24 hours, you may see fewer wet diapers. One exception to this is if your baby is born very over-saturated. If mom had an epidural and had bag after bag after bag of IV fluid, moms are going to have a lot of fluid retention, and sometimes the babies are born with a lot of excess fluid on board. And so this makes it look like the baby has dropped more than 10% of their weight by the second day. And there's a lot of health providers who think that when we are judging for looking at the percentage of weight loss, we should not be looking at the birth weight, but instead we should be looking at the day 2 weight, because if a baby is born with a lot of excess fluid on board and spends their first day peeing out a whole lot of this excess fluid, they really haven't lost body weight. They were just born a little overhydrated and now they're regulating it out. So that's one thing to think about. If the baby has peed a lot on day 1 from all that extra IV fluid mom had, it's not surprising if they, by day 2 to day 3, go down to that 10% weight loss. Very common concern on day 2 is the sleepy baby, and some tricks that you can use both in the hospital and later when you're home is to stimulate your baby to try to get them to be a little bit more awake and alert when you're trying to feed them. So you can unswaddle them and undress them. Sometimes just letting them kind of wake up and acclimate by doing direct skin to skin, real skin to skin like we talked about. Mom's bare chest, baby is down to the diaper, and then you can put a little thin blanket over the two of you for warmth. Daze maneuver is a reflex. You can look this up on YouTube or something. I can put a link up later. I'll find one for you, where you're holding your baby flat, and then you sit them up at a 90-degree angle, flexed at the hips, and you do this slowly and repeatedly, and just like a little child's doll with the eyes that move. You lay the baby down and the eyes close, you sit the baby up and the eyes pop open. This is actually a reflex. It's called the Daze maneuver, and this is a way of irritating your baby and waking them up, because if they are in a light sleep or drowsy, repeatedly laying them down and sitting them up in that 90-degree sit will force them to open their eyes and prevent them from having a nice relaxing sleep, which is important if you're trying to get your baby feeding and not sleeping. Another thing that's good to know is watch your baby for light sleep stage. So when they're twitching, when their mouth is making little nursing movements, when you see their eyes moving, you see cute little expressions flicker across their face, maybe they're moving their hands and arms a little bit, that's a light sleep stage, and you'll be more successful trying to rouse your baby to feed them at that point, as opposed to just because the clock said it's been 3 hours and trying to wake your baby up out of a deep sleep. It's very hard to wake a baby up out of a deep sleep, and nobody likes it. You know how you are when you're sound asleep and the alarm goes off or the phone rings and it jerks you right out of a deep sleep, and it's just not a good feeling. So it's better to wake up slowly when you're in a light sleep stage. While you're feeding, it's very common as soon as the baby is against your warm body, is suckling, has a little bit of milk in their belly, it's very typical for them to fall back asleep. And most moms are trying to keep the baby awake and feeding at the breast so that they feel like the baby got a pretty good meal. So some things that you can try are to kind of gently bother or irritate the arms and legs, rub the little toes, touch your baby's hands, bring their arm up and down, flex their leg, flex their arm a little bit. You want to, essentially you're trying not to do rhythmic patting and rocking. Those things are very relaxing. So this is kind of more like an annoying random poke or prod or nudge that just, you tap them here, then you squeeze them here, then you flick their ear, then you move their leg, and so on. Again, the massage and compression often helps milk flow better, and it reminds the baby to suck a little bit more. I would not feed a sleepy baby in a rocking chair or glider rocker because that just helps them fall asleep faster. Sometimes a damp washcloth on their face can help, and in between breasts you can try sitting them up to burp them or changing the diaper. Sometimes that helps to rouse them a little bit. And then switching from one side to another sometimes is a good way to kind of rouse your baby and stimulate them to eat just a little bit more. I'm not going to spend a lot of time on this topic, but just, I felt it would be amiss not to bring it up at all. Let's see. Hold on, I'm just looking for my pointer. Okay, so you're always wanting your baby's nose and belly button to be in a straight line. See how if we could see the baby's spine, their cervical spine, their neck spine, their whole body is in a straight line, and that's good. What you never want, really, is for your baby to have their head turned to nurse. So imagine if a baby were laying on their back, but they turned their head to feed. So everybody at home or wherever you are, take a mouthful of spit and turn your head to the side so that your chin is over your shoulder, like you're looking way off to the side, and try to swallow. Not very easy, is it? So you always want your nose and your belly button. Look at yourself. Your nose and belly button in a nice straight line. That's what's going to make it easiest to swallow. And then another thing is that babies feed much better and they can open their mouth much wider if their head is tilted back slightly and not tucked forward. So let's try this one. Everybody bring your chin up just a little bit, tilt your head back a little bit, and open your mouth nice and wide. Great. And now tuck your head forward, so exaggerate this movement a little bit so your chin is down by your chest, and see how wide you can open your mouth. Not so easy, is it? And then finally, the arm, make sure that you're not trying to feed your baby swaddled or have the baby's arm tucked between the two of you, because that does keep the baby a little bit further away. I have a whole webinar that goes over these types of positioning tips. So that's what I would recommend if you're interested in learning more specifics about that. Some other just very basic but important keys to positioning. In the early days, make sure you want your baby to get as much access to breast tissue as they can. So watch what your fingers are doing. And in this picture here, this index finger is beginning to impinge on space where I would want that baby to be latching. So the hand really should be much further back in the breast tissue and not near the nipple and areola. Here, I like to suggest using a rolled receiving blanket. This is supporting mom's wrist. You can use a couple of rolled blankets, maybe one to support the baby's head, and so on. I like to have these little receiving blanket sausages rolled up and ready so that wherever it seems like one would be beneficial, you can tuck it there. This is a nice job for partner to do. So once you get yourself and baby positioned and they're latched, you want to make sure that you can drop your shoulders and relax your arms. You want your arms and your wrist and your baby well supported. You don't want to have to stand, sit there all rigid, afraid to move because you don't want to lose the latch. So having various types of rolled up blankets, maybe a nursing pillow, maybe a bed pillow, maybe a couch pillow. So you'll have to experiment with different heights and different firmnesses to see what it is that is going to work best. This is another example of this baby's nursing in the football hold, and some key tips I want to give you here is you want that wide open C hand like this, but much further back in the breast, not the way this mom is cupping the back of the baby's head. So two things going on here. If you push on the back of the baby's head, if you try to push the head into the breast like this, the baby's chin is going to curl and tuck down toward their chest, just like we talked about, which makes it harder for them to open their mouth and get a big latch. Also, if mom's hand is touching, I like to say don't put your hand anywhere a hat would go. So you want to support your baby's head like this, the nape of the neck. So this is a cross cradle position, fingertip and thumb behind the baby's ears, not anywhere a head would go. Babies have a reflex and they will push their head back into the warmth of your hand and therefore pull themselves off the breast and get frustrated because neither of you understand that's what's going on. So you want to be supporting the nape of the baby's neck, fingertip and thumbs behind the ears, and not pushing on the head or touching or irritating the head where a hat would go. And then finally, the other thing I made sure to add here to remember to tell you is to make sure your baby's feet are not pressed against the chair or the bed. So in this football hold position, baby's feet, this baby's a newborn, so she's small, but if the baby was a little bit longer, you want to make sure that the feet are not pressing against the back of the chair. You can either flex the baby's hips so the feet are kind of pointing up, or if the baby was older and longer, put a pillow behind you, mom, so that you're sitting a little, you're relaxed back, but you're sitting a little further back in the chair so that there's more space for the baby's feet. And in the cross cradle position, if you're trying to nurse in a glider rocker or a chair with arms, in this position, the baby's head sometimes can hit the glider rocker arm on this side, but more importantly, the feet can be pressed up against the edge of the couch or the armrest of the chair, and babies have a reflex. If their feet are pressed up against something, they are going to push and arch off it. So they keep arching and pushing away from the breast and getting very frustrated, and moms get frustrated too because, again, it's a reflex and the baby can't really control it, and mom doesn't understand why the baby is arching and crying at the breast instead of nursing. And then this is called the laid back or biological nursing position, and the baby is actually just draped over the reclining mom, and the baby is on top, more or less. So again, I have a webinar that goes over all of these in more detail. I did this one. So here's, I think we're getting toward the end. I wanted to talk a little bit about the hospital experience and some, the good, the bad, and the ugly. Rooming in, so rooming in means that you're keeping the baby with you and the baby is not living in the nursery but coming to you for feedings. And I understand that you don't always get to choose this because there are still, despite what the evidence-based practices are, there are still some hospitals that require certain stays in the nursery. For example, when the pediatrician rounds in the morning, the babies are all lined up in the nursery and so on. However, rooming in is what is what is evidence-based and best care for mom and for baby, because it allows you to get to learn your baby's care and rhythms. You can listen to the sounds that your baby makes, and you won't be quite as freaked out when you're at home, and you'll learn things like if the baby is coughing and choking on mucus and you panic and you hit the emergency button and 3 staff members come running in and you say, the baby's choking. And they say, yes, he's got some mucus, and they pick him up and turn him on his side and pat his back, and the baby hawks up a goober. You'll have seen that and learned that, and when it happens at home 2 days later, you won't freak out. Now, if that happened in the nursery, you didn't know it or see it, and you will freak out later on when you're at home. Also, when the baby is rooming in with you, they are under your direct care and supervision. When the baby is in the nursery, despite your best attempts at what you might ask for, you might say, please bring the baby to me when she wakes up so I can nurse her, or I don't want her to have pacifiers right now, and that may or may not happen, depends. So rooming in is what I would absolutely recommend. There are some people who will say to you, make sure have the baby stay in the nursery at night because it's the last good night's sleep you're gonna have. And I would say that if you're solo, if you're a single parent, you don't have a partner with you, or you don't have a helper or family member or your partner staying with you, if you're on medication, if you're so exhausted that you're not going to be able to respond to your baby's sounds, then perhaps it is definitely safer for the baby to be in the nursery. Other than that, you want to keep your baby with you. You will get a lot of conflicting information in the hospital. This comes up over and over again. You may have 6 or 8 different caregivers coming in and telling you conflicting information. So the pediatrician may say one thing, your morning nurse and then your evening nurse will directly contradict each other, and the pediatrician and then the lactation consultant will come in and say something altogether different. Expect that, take what works for you and leave the rest. Realize that when you get home, you can take a deep breath and figure out your own game plan. But understand that the hospital is not a place for resting. You will get a lot of disruption. There's a lot of people in and out. You will be exhausted, and you will not be able to learn and retain a lot of valuable information during that time frame. It's also, hospitals are an anxious place. There'll be scare things going on. So they'll say, oh, she's lost 9% of her weight, and if she loses a little bit more, they're going to insist that you supplement. Or, oh, the bilirubin level is this, she might need to go under the lights. And it's really a freaky time. So just be prepared for that. And I'm not, as a nurse, I'm not dissing hospitals and hospital care. There's reasons that we have policies, and there's a lot that's going on. There's a lot of things that you may not be aware of that your nurse is also responsible for, and so on. Just realize that you may or may not get what you're looking for from the hospital experience. And you will notice that the staff varies. So you'll have a couple of great nurses who are so helpful, and you learn a lot from them, and they stay and they help you get the baby latched on or teach you a new position. And then you may have another nurse who comes in and just basically takes over or wants to do it her way. So just understand that you're dealing with individuals. And when you get home, first of all, you can advocate for yourself and your baby while you're there. But when you get home, you're running the show. I can't stress enough limiting visitors. You don't want your hospital to be an open house with a million people coming in and sitting in your hospital room like it's a hotel room, bringing you flowers and so on. You're there for such a short period of time. Learn to take care of your baby, recuperate yourself, and then you got to get out of there. And when you go home, same thing. You don't want to be entertaining guests during the first 1 to 2 weeks. So just keep the visits very short, keep them to immediate family. Put pictures on Facebook, and people will be disappointed but understanding. And then the other thing I will mention to you is when you get home, day 3, 4, and 5 are often the most challenging days because your milk does not come in typically until that time. And once your milk comes in, it changes the whole terrain of the breast and breastfeeding. Usually the baby is sleepier. There may be more latching issues, sometimes sore nipples, things like that. Get your breastfeeding support in place ahead of time so that when you get home and you have challenges, you can access that stuff in a jiffy. And then I put a nipple shield here to remind myself to tell you that it's very common for moms to end up with a nipple shield in the hospital and then be sent home and really not have a lot of advice or support about why they needed a shield, which is sometimes a pink flag for breastfeeding challenges that can be resolved in other ways, or how to move away from the shield as well. So what if you're discharged home at day 2 or day 3 and the baby is not nursing or nursing well? One way or another, you have to get that milk moving, and obviously one way or another, gradually the baby needs to be eating. So it's all about getting the milk supply initiated and maintained, and then feeding the baby the colostrum and the early milk, and then the milk that you're expressing, and working on the pieces of the puzzle to put the healthy baby, the lactating breast, and the challenges all together and get it up and running. And we have a webinar that's called Slower Starts to Breastfeeding that really kind of holds your hand through each step here. But I need to emphasize the importance during day 1 or 2, if you're separated from your baby, if your baby is super sleepy, if your baby is not latching well or latching at all, if you have nipple pain or damage that's getting in the way of breastfeeding, you've got to get that milk moving. So why is the 8 ball here? Because 8 times in 24 hours, that's what it takes to initiate or maintain milk production. So either the baby or the pump, but one way or another, thorough and efficient milk removal, 8 times in 24 hours. Here's a little excerpts from our library of webinars that I would recommend on related topics. I think I mentioned some of these already. Positioning and latch, sore nipples, as I'm sure many of you know, is a common new mom complaint. Slower Starts to Breastfeeding is one of my favorite webinars because it keeps your eye on the prize and looking at the big picture. Engorgement and overfullness is something that many moms experience day 3 to day 6, and you want to be using warmth before, ice after, ibuprofen, gentle massage, and perhaps some expression, manual expression and or a breast pump. If the breasts are very, very hard, firm, uncomfortable, and it's making the baby hard, it's hard to latch. Nipple shields, if you were sent home with a nipple shield, this would be a good webinar to watch. And then if your baby did come early, this is another good one. I love this picture. I remember the mom's name as Mrs. Miner, and they have a dog named Oscar, but I just love this picture. She's one of our regulars on Twitter and the webinars, and her little boy, she loves to hang out and listen to the sleep and the breastfeeding webinars with her baby. So I just love this picture with the computer in the background. Okay, next week we're going to talk about the next stage. I sure hope Sarah's back next week because she'll perhaps be in the stage and can tell us her experience. Not to, again, I'm not, this isn't about saying, oh, it's so hard and it's all negative and all of these things. This is the reality, and breastfeeding is challenging, and these are the bumps in the road that you can and will overcome. Not all of these, but, take your pick. I'm sure that majority of you had at least one of these. These two shall pass and be resolved, and so we'll go over the scenario, the causes, the how to address it, and how to prevent it perhaps, and how to deal with it so that you will go on to become a wonderful breastfeeding family. So please do come back next week for more of that good stuff. Remember to sign up for our newsletters, read our blog, like us on Facebook, and follow us on Twitter. I will answer. I'm sorry. I kept saying Sarah, but Sarah's the one with the 11-day-olds, and now I'm looking in the questions and answers. And we had the one mom who's due today. Is that Jen? I can't see now. Jen's due today. So I hope Jen comes back next week and tells us what her hospital experience was like and what the first 2 days at home was like. Okay, so let's see. Let me answer Sarah's questions because she's got an 11-day-old, feeding well. Mom can get her in a good position. She's having lots of spit up. She eats very fast, guzzles, and mom feels she has to pull her off the breast and burp her. Otherwise, she drinks so fast, loses the suck, swallow, breathe, gasps and throws up. Is it possible milk is flowing too fast? She only feeds for about 6 minutes on one breast before falling asleep. Excellent, Sarah. Congratulations. Yes, it sounds like you have a heavy milk letdown, and the milk is flowing fast. And hold on a minute. If I can try to change my slide deck. I would recommend that you look at the document. I would recommend that you look at the Positions webinar because I have lots of information on this, but I'm pulling up the slides now so I can give you a quick overview. But basically, my analogy is that perhaps you are, imagine that you were thirsty and I laid you down on my lawn and put a hose over your mouth that you had to try to keep up with. So instead, you would probably rather me hold the hose out and you lean over and slurp up the water that you want. So if you have an overactive letdown, which is what we're talking about, here we go. Special situations and positioning. Here's a mom who has an overactive letdown. Some babies will pull off the breast and cry. Some babies will pull off the breast and wait, and some babies will stay on the breast but cough, choke, and splutter. But what you're going to find most helpful is to change your positioning a little bit, probably just for the first few minutes of breastfeeding during the initial milk letdown. This baby dominant position can work well, the laid back biological nursing. Here is, I love this picture because look at the fountain and then the statue in front of the fountain, and then mom is nursing in the exact same position to make a nice picture. But you can see in both of these positions, the baby's head is higher than the baby's hips. But even more beneficial is nursing in this upright position. So what can work well is if you lean way back in your chair and put your feet up on the coffee table and bring the baby up and over the breast instead of level or under the breast. And that will slow the flow of milk by gravity, and it will help your baby coordinate the suck, swallow, breathe a little bit better. It is not dangerous for your baby to cough, choke, and splutter at the breast. She is not going to choke or aspirate on your milk, and she will learn to cope with the flow as she grows. She'll grow into it, and keeping the baby a little bit more upright and more dominant over the breast will be helpful. Okay, and this mom says, I'm hoping to get information on how to deal with oversupply in the beginning. I've heard that happens with second delivery. I nursed my twins, congratulations, first round, so feel like I will have quite a bit of oversupply. Do I just pump when I'm comfortable to relieve the discomfort? Okay, yeah, so couple of nice things might happen this time around, which is that your milk may come in sooner. That usually happens with a second delivery. I wouldn't necessarily worry that you're going to end up with chronic oversupply as long as you don't perpetuate that by increased constant pumping and becoming pump dependent, as though your body thinks it's breastfeeding twins because you're breastfeeding your baby and then you're pumping 5 or 6 times a day, 2 and 3 and 4 ounces at a time. So I would treat for engorgement when your milk comes in. If you feel quite full, you're going to nurse. If you need to soften the breast ahead of time to help your baby latch on, as I like to say, an engorged breast is so hard to latch onto. It's kind of like a beach ball with an M&M glued to it, covered in oil, and the baby is slipping and sliding and trying to latch onto that really firm skin, and they end up just hanging on to that little, the little bit of the nipple that they can feel, and moms can get very sore. So if you can soften the breast a little bit, the baby will get a deeper latch, and then they can drain the breast a little easier. I would pump if you are hard and uncomfortable, as opposed to just feeling a little full. Use lots of ice. Bags of frozen peas or frozen corn work very well for ice packs in between. Ibuprofen is going to be helpful too. And usually within 2 to 3 weeks, your supply will regulate to your baby's needs. It's also not a bad idea if you're going to be going back to work and if you want to begin to put some milk in the freezer. If in the morning or if during, once or twice a day, if you're feeling very, very full, then you could express milk if you want to express and put that milk away. But I would not get into a routine where you're pumping frequently, more than once or twice a day maximum early on. And sometimes people have heard if you pump when you're engorged, you'll just encourage more engorgement and so on. And engorgement is different than oversupply. Engorgement is interstitial fluid and edema in addition to milk. It's not just milk that the breasts are full of. So engorgement is usually within the first week, and not all women get engorged. Some women just get full, and then oversupply is what happens when the body thinks it needs a lot more milk than it actually does, and then because moms are uncomfortable, they start pumping off that milk, and then before you know it, your body thinks it's feeding triplets. And you need to keep pumping, because if you don't keep pumping, you're uncomfortable. So that's the scenario you want to try not to get yourself into. But I don't think that you're going to set yourself up for oversupply simply because it's your second baby or you breastfed twins. I think that your milk will come in early. If you have a vaginal birth, your milk may come in day 2 to day 3. If you have a C-section, your milk will come in probably day 3 or day 4. Both of those scenarios are about a day earlier than a first-time mom would have. And you may have more uncomfortable fullness or engorgement because nursing twins, you probably have had a lot of breast proliferation first time around. But I think you're going to have a great breastfeeding success story to share with us. All right, I think we better wrap up. Thanks for coming, everybody, and thank you, Hillary, for being our moderator today. I will check the chat, which I don't look at the chat the whole time because I can barely breathe and talk at the same time. Never mind read, and never mind changing the slides. So please do come back next week. Share the info with your friends and email lists and Facebook and so on. And of course, every Tuesday we have an infant toddler sleep webinar, so please come back for that. Tonight we're doing a webinar on the family-centered C-section. I'll put the link on that. And then in 2 weeks' time, we're doing an evening webinar on positive discipline for 1- and 2-year-olds. So those of you with toddlers at home will also find that one helpful. And I'll put the links to all of those on. Thank you, everybody. Thank you, Hillary, and happy nurturing. And Jen, I wish you a blissful and happy, healthy birth. Sarah and all of the others with brand new babies, congratulations. And Kara, it's always a joy to have you.